Morning, everyone. I'd like to ask all the board members and our staff to please turn your mobile devices to silent so we can reduce some interruptions. For the members of the public, you may notice that board members are accessing their laptops, their phones, or other devices during the meeting. They are using these devices to access board meeting materials that are in electronic format. If you are a member of the media and you require assistance or information, please see Aaron Bone in the back, waving his hand. This is an official business meeting of the Medical Board of California, and disruptions of the board's business will not be tolerated. Government Code Section 11126.5 allows a board to remove people who willfully interrupt a meeting and to clear the room if order cannot be restored by removing or muting the disruptive people. The board welcomes public comments on any item on the agenda, and it is the board's intent to ask for public comments prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please just raise your hand or come forward and you will be recognized. As Sean mentioned, this meeting is also being streamed via WebEx. Individuals attending the meeting remotely via WebEx will have an opportunity to provide public comment and will be assisted by the host, who will be facilitating the WebEx meeting. During each agenda item, the host moderating this WebEx event will activate the hand raising and Q&A features of the WebEx and will ask anyone wishing to make a public comment to indicate so by raising their hand or entering yes in the Q&A window. The host will then call on individuals who indicated they wish to make public comments by the name provided by the individual, which may be a pseudonym. When called upon, the host will unmute the microphone of the individual and they will have 3 minutes to make public comment, but this time period may be reduced depending on the number of people who wish to speak so that more people may be heard. The host will audibly announce when 30 seconds remain to conclude the public comment. After the individual's time for public comment has lapsed, the individual will be placed back on mute, and only one public comment per agenda item is allowed per attendee. I would like to remind all speakers to please stay on topic and keep your comments to 3 minutes or less. Today's meeting will be run according to the Open Meeting Act as required by law, and we do plan to end today by 3 p.m. I would like to officially call the meeting to order at 9:05 a.m. And Ms. Struther, if you could please call the roll.
Dr. Ayala Rodriguez.
Here.
Mr. Arkatov.
Here.
Ms. Chung.
I'm here.
Dr. Mahmood. Ms. Rimke.
Here.
Dr. Solis.
Here.
Dr. Thorpe.
Here.
Dr. Tolbert. Ms. Torres. Dr. Sai.
Here.
Mr. Watkins.
Yeah.
Dr. Yip.
Here.
Ms. Lawson.
Here. Thank you. A quorum is present. I would like to remind members again, we'll be taking a roll call vote on all action items. We're going to get right into it and move on to agenda item 13, presentation on workforce shortages, licensure portability, and the additional licensing models. And I'm very pleased to introduce our first speaker, Dr. Hank Chowdhury. Dr. Chowdhury is the president and CEO of the Federation of State Medical Boards, which operates the Federation Credentials Verification Service and co-owns the United States Medical Licensing Examination with the National Board of Medical Examiners. Dr. Chowdhury is also a clinical associate professor of medicine at the George Washington University School of Medicine and Health Sciences in Washington, D.C. In 2022 and again in 2023, Modern Healthcare recognized him as one of the 100 most influential people in healthcare. And additional details about Dr. Chowdhury's bio are included in your materials. Dr. Chowdhury, it's been a pleasure to get to know you over the years, and we very much appreciate you joining us to present on this crucial issue. Welcome.
Thank you very much, President Lawson, Executive Director Verghese. Thank you for the members of the board for inviting us. With me is Ms. Andrea Chacon. She's FSMB's Chief of Staff. We're delighted to be with you. This is maybe my third or fourth visit to the medical board. I think the last time was before the pandemic, which seems like such a long time ago. But I'm delighted to meet with you this morning to give you an update on what's happening, not only at the FSMB, but also around the country as it relates to workforce issues. That's obviously a concern across the entire country, and there are a number of interesting things that are happening around the country. So let me begin with that. First, I bring you greetings from our FSMB Board of Directors. We represent, obviously, many states and territories across the country as well, and we include not just physicians, we have public members, we have executive directors as well. So about 4 or 5 years ago, probably Massachusetts was one of the first states to look at this issue broadly and put together a special commission to study their workforce needs, especially in their suburban and rural areas. But Tennessee was actually one of the first states 2 years ago to put together a pathway, which was novel at the time, a pathway to enable internationally trained physicians, as opposed to just international medical graduates, to be able to get licensed through a process, an expedited process, if you will, where if you had already trained overseas, you maybe did not have to necessarily do that training again in the United States. As you may know, for decades, the norm across all 50 states and territories had been that if you're an international medical graduate who wishes to get licensed in any of the jurisdictions in the U.S., that you had to first be eligible, of course, but also to complete residency training in the United States. And again, it was cited as something that needed to be done to maybe avoid redundancy and so forth, but it caught on, and a number of states liked the idea. And next thing you know, in 2 years, we have 18 states that have passed laws to enable internationally trained physicians to enter a pathway to become licensed in their jurisdictions. And I'll go over some details in a little bit. Now, even though 18 states have done this, and there are about 13 states that have introduced legislation, it has not really taken off, and I'll explain a little bit why in a moment. But if you look at this map, you'll see the states in dark blue are the states that have passed these laws, sort of a Tennessee type approach. Light blue states are the states that have introduced legislation. And you'll notice California and part of Washington and part of New York are in the yellow. And that's because these three states have had longstanding efforts to try to address their physician workforce issues. In the case of California, through your physician licensure program for physicians who speak Spanish who are from Mexico, for example. Washington also had a similar program. New York had a similar program for certain qualified internationally trained physicians to get licensed. But this was a much more broader approach that is being taken by a number of states. So a number of states, they started to do this on their own in trying to figure out, how do we do this? If we do want those who are trained overseas, how do we know their training overseas meets requirements? Because while they value having qualified physicians able to practice medicine in their jurisdiction, they're also concerned, obviously, about patient safety, making sure there are guardrails in place so that this is done thoughtfully. And after a while, as the first few states started to pass these laws, we noticed that the FSMB, some differences in them. And so a number of the states turned to us and said, you know, we're interested in doing this. Could the FSMB provide some guidance? For those of you who don't know, the FSMB was created by the state licensing boards back in 1912 to assist, provide resources, share best practices, provide education, and to answer questions and be helpful. And so that's very much what we do. But on this particular matter, we realized we couldn't do it all by ourselves. We needed some additional expertise. So we created this advisory commission on additional licensing models. Three main organizations were a part of this: the FSMB, the ACGME, the Accreditation Council for Graduate Medical Education, which oversees all residency and fellowship training in the United States for both MDs and DOs, as well as our colleagues at INTELF, which is the umbrella organization that oversees ECFMG, the Educational Commission for Foreign Medical Graduates, and their foundation. And so this is a picture of not only the three organizations, but also many of the leaders in the House of Medicine that we partnered with as part of this advisory commission to make sure that whatever recommendations we made were thoughtful and thoughtfully considered. So we had a representation from the American Medical Association, American Osteopathic Association, Association of American Medical Colleges, American Association of Colleges of Osteopathic Medicine, for example, National Board of Medical Examiners, the World Federation of Medical Education, for example, just to make sure we were thoughtful in how we proceeded. And so we wrote about this not too long ago in Annals of Internal Medicine. July 1st, as a matter of fact, is when this article came out, where we shared sort of the story of how our advisory commission sought to present this information and to give guidance to our state licensing boards. And I'll go over the first set of recommendations we made back in February of this year, and then Andrea will go over sort of, we're very close to finalizing a second and final set of recommendations. So our recommendations, and I won't read every word on this slide, but just to give you a flavor for how we think eligibility criteria make sense for those states who want to go down this road. Number one, and this was felt to be quite important by the state medical boards, and you can imagine why, is that legislators can come up with the sort of 5,000 foot or 10,000 foot guidance, and that's fine, but it should be up to the state licensing boards to do the details. The rulemaking authority, because that's what state medical boards do best. They know it. They've been doing it for years, and they understand some of the nuances. Once you put something in a law, sometimes it's difficult to navigate around if it's too specific or too prescriptive. So number one recommendation was it's okay for states to do this if they're interested, but leave the details to the state boards and allow them some flexibility as events change or as circumstances change. Number two, any international physician who's trained overseas who wishes to enter these pathways should identify an employer. And we define in our detailed recommendations, this is just an overview, that the employer should be, for example, it could be a hospital that has an existing training program that has some experience in oversight and supervision of other physicians, for example. It could be a federally qualified health center. Again, a structure. What the commission wanted to avoid was solo doctors saying, well, I need another doctor, maybe I could be the employer. The thinking was there's too many conflicts of interest if that were to be the case. If we're going to do this, let's do this with employers that have experience in doing this. Number three, the individuals should obviously have graduated from a recognized medical school around the world. There are more than 171 medical schools from which graduates have come to the United States, but there are more than 2,300 medical schools in the world. How will that be figured out? Well, ECFMG plays an important role in certifying and graduate and making sure those individuals come from recognized schools. There is a world listing of medical schools that are recognized that is traditionally used by most medical schools. Fourth, there should be completion of postgraduate training outside the U.S. Now, the tricky part there is how do you know it's equivalent to the training in the U.S.? You don't. There is no universal recognized system, although the World Federation of Medical Education is embarking on a process by which they will put together some framework, but it's really up to the state boards to figure out if someone who's trained overseas, if that training meets needs of that jurisdiction. I say, now, why is this even a criteria? Because there are 2 or 3 states that are so desperate, you might say, to get physicians to come in. They've said that even if they haven't had training, they would accept practice experience as a requirement for this pathway. The commission thought about this, and we felt that on a case-by-case basis, I'm sure there are physicians who are brilliant in what they do, just based upon practice experience. Maybe they've worked as an apprentice under another doctor, but the preference is that they've completed some sort of formalized postgraduate training, and that any other scenarios should really be taken on a case-by-case basis. Number 5, they should already possess a license to practice medicine in another country. Number 6, they shouldn't have been out of practice for many, many years. As you know, many states have requirements for physicians who leave licensure for whatever reason, and then wish to come back for re-entry. In most states, it's a 2 to 3 years that if you haven't left practice for more than 2 to 3 years, there's an easy pathway to come back. But if you haven't practiced for 2 to 3 years or more, many states require additional, specific requirements. It could be an examination, could be demonstration of knowledge and skills. I think the commission wanted to avoid somebody who's been out of practice for 10 years, maybe is overseas, and sees this as an opportunity to help out. Number 7, there should be a period of provisional licensure. So no state is open to just giving a license to practice medicine, even though there's not a residency requirement for the U.S. training for this. There is a requirement of a period of provisional licensure where the employer would be required to supervise and make sure the physician is progressing and ready for an unlimited, unrestricted license to practice medicine. Number 8 was to make sure that once that provisional licensure period is done, that there's an assessment made of whether that individual is truly ready to become eligible for an unrestricted license. It shouldn't be automatic, in other words. And then finally, number 9, since this is quite new for the states, our recommendation is that states keep track of who's applying for these types of pathways, what kind of successes are they seeing, what works, what doesn't work, because it's important for that kind of sharing for all of the states to learn what works and what doesn't work. Let me turn it over now to Andrea to go over the rest of this.
Thanks, Dr. Chowdhury, and it's really a pleasure to be with all of you. As Hank talked about the first set of recommendations that were issued earlier this year, they were really focused towards state boards and legislators. As you thought about the eligibility requirements that would be built into statutes or would be considered as part of your rulemaking process. The second set of recommendations are really focused in on that recommendation 7 that Hank talked about, what happens during that provisional period of licensure. And these recommendations are really targeted towards state boards, but also to the employers. As you think about, the kinds of employers in that recommendation number 2 in the previous set, or here, they should be the type of employer that has the structure and experience to provide oversight and supervision of these physicians within these pathways. So if you take a look at these, what we're calling assessment and supervisory considerations, and thinking about making sure that the physicians that are within these pathways on a pathway to full and unrestricted license, what should happen during that provisional period of licensure? And really, it should, in some respects, look like some of the requirements that physicians see going through a residency track. And so they should be able to be evaluated on all 6 general competencies. And in doing so, there should be a formative needs assessment at the beginning of the supervisory period, so we know the kind of skills this physician has and where there may be deficiencies, so that during this supervisory period, they are addressed and we ensure that the physician is able to provide safe and quality care. It's important to know what scope of practice the physician is intending to practice, whether that's primary care or a specialty, and they should be evaluated within that scope of practice, whether that's through a specialty-specific exam or another way that's taking into account what patients they're going to be seeing and in what areas they will be practicing. The assessment should be longitudinal and periodic, and it should be multimodal in the sense that not only are you looking at their knowledge, but you also want to look at their clinical skills. You want to look at how they are interacting with other staff, how they are interacting with their patients through some sort of multi-source feedback mechanism. And you want to look at their documentation. It may be that things like documentation through the medical record are going to be a little bit different in the United States than from the area in which they are practicing. And so doing that audit and review of the medical records is going to be an important thing to do. Most importantly, at the end of the supervisory period, we want to make sure that this physician is able to demonstrate that they are able to engage in independent and unsupervised practice. And so all the more reason that going through this longitudinal and periodic assessment through the supervisory period ensures that this physician is able, that you feel able, that you're able to grant that license, that they can engage in independent and unsupervised practice. And of course, that the level of supervision based on that needs assessment should really be tailored to the competence of the individual physician. And so thinking about, do they need full supervision? How much supervision is that going to look like? That all should be taken into consideration through these assessment modals. Of course, we think that the supervisors should be physicians, and MD or DO or equivalent. And most importantly, that one of the things that the commission has really thought a lot about is that we're not creating a mechanism for these physicians to be taken care of or taken advantage of. So we want to make sure that their rights are protected, that they are being treated equitably during this supervision period. As Hank mentioned, the final guidance document actually is going to be coming out next Wednesday. As I mentioned, it is targeted towards state boards and employers. So within those recommendations, you're going to see considerations and responsibilities for state boards as well as for the employers themselves. This will also be accompanied by a toolkit. Now, all of you here have programs like PACE, for example, that I'm sure that you utilize, and that may be something that is a resource for you for some of these physicians, especially where there may be questions raised about their competence. But this toolkit will be an additional set of recommendations that the board may wish to consider as you're doing your rulemaking, but certainly will be a resource for the employers that you identify that will be able to bring these physicians through these pathways. I won't spend a lot of time on these slides, but to show that we've taken a look and analyzed the legislation that has come through these 18 states, and we compared them with each other as well as some model language that was developed by Cicero, which is a think tank based out of Texas that was one of the drivers towards this legislation that has been enacted in 18 states. And we compared them with the eligibility requirements that Hank had mentioned and a couple of other things. And so the green is where you'll see a fair amount of consistency across the legislation. The blue is where there's some variability. On the next slide, I'll show you some areas of red where there's very little consistency. But just to show that, I think if you would have looked at this chart last year, there would have been even more variability. So I think that the guidance from the Advisory Commission has really allowed for some consistency and for considerations for boards and legislators as you've been thinking about what this legislation and your rulemaking might look like. On this slide, I just wanted to point out a couple of things. Again, just a continuation of those requirements from the first set of recommendations. The standard reporting requirements is something that really has not been built in any significant way into the legislation. And Hank's going to talk a little bit about sort of the implementation lessons learned to date. And I think it's really important to think about how you collect data to make sure that these pathways are actually intended or are positioned to meet the intended purpose, which is to, solve some of your workforce issues. And I think that remains to be seen. And so this is really just for you to take a look at as you, as any state thinks about what eligibility requirements they may build into their statute or rulemaking, so you have an understanding of what other states are doing or what you could be doing as you enter into considerations. And Hank, I'll turn this over to you for the final slide.
Thank you, Andrea. So this is our last slide, and then we'd be happy to take any questions. I should mention that the Advisory Commission is not, and us here, we're not here to endorse necessarily this pathway. We're not sure if this is the best way to address workforce needs, but since a number of states are interested in it, we're happy to partner with our colleagues to figure out how to do this if you're interested in going down this pathway. There are some considerations. One is the pipeline has been minimal to date. There's been a lot of interest with 18 states doing this, but there's really right now only 2 physicians who are actually in the pathway. And part of that is because there's a little uncertainty on the part of the state boards who have to implement these laws about how to do this right. They have to create an application. They have to make sure it's thoughtful. They have to make sure ECFMG certification, USMLE, all those things are in place. And they have to help the physicians, in some cases, find employers who are willing to do this. It's not clear where the funding for these kinds of things will come from. Only one state proposed some funding mechanism, and that legislation has not yet passed. So there are some real questions about whether this is, A, the best way to do this, and B, whether it's going to be able to succeed. Determinations of substantially similar training, it may be easier in some countries, it may be very difficult in others where it's not a clear-cut similarity in terms of even the number of years, for example. And then there are, of course, federal immigration uncertainties. It's interesting that a broad swath of states are interested in these pathways because the federal government has different approaches towards immigration, and we'll have to see how this plays out. In most cases, individuals coming for internationally trained physician pathways will need H-1B licenses. It's not clear if the government will be limiting those kinds of visas. They did under the first Trump administration. It's not clear that the current administration will put some limitations on that. So there's some big questions marks related to immigration, which are obviously above state requirements. Quality of care assurances, are going to be employer dependent. So you're going to have to trust your employers to make sure they're doing what's necessary. Remember, this is not a repeat residency program. So there's a reliance on and a trust of the employers to do what's right. And then ultimately, is this going to make a difference? Some states have actually said that those who enter these pathways during their provisional licensure period must work in an underserved area as defined by the state board, which makes sense. But once they get their full and unrestricted license, in some ways, they're a free agent. They can go anywhere they want within the state. How do you retain them to work in those underserved areas? Recruitment is one thing. Retention is sometimes challenging. So I'll stop there and happy to take any additional questions. Those are our email addresses. But thank you again for this opportunity to speak with you.
Thank you both for being here. Questions from board members? Dr. Yip.
Thank you. Thank you so much for the very needed information. I actually have personal experience. At UC Irvine, we tried to recruit urologists from Canada, and they were fellow, and then they stay on, and that's easier with the H visa. I think the roadblock is the immigration status. We're trying to recruit urology in Canada who is being fellowship trained, but they require to take the H visa, which actually in the private sector, you go on a lottery. It's not like you apply, you get it. So I think what we do here probably need to work with the federal government on the immigration status. That's the biggest hurdle. The second is examination. Some of the young kids, they don't want to take step 3. They want to just come in and do it. So I think from the human resources standpoint, we should look at our neighbor, the Canadian and Mexican, which is close, which is badly needed. I think if we can work with whatever federal branch to work that kink out.
Thank you, Dr. Yip. I think your points are very well taken. I think the larger immigration piece is the biggest question mark. For those international graduates who come in for training, they come in under J1 training licenses, which is a whole different category. For physicians who are already trained under supervision, it's going to be something that we'll have to see what comes out of Washington, D.C. I should mention almost all states have somewhere in their statutes an ability for exceptionally qualified physicians to get licensed. And that has always been around. It's not easy, but if there is a need as identified by a region, an employer, or by the board, there are those pathways. They're just not easy. This approach, though it has a lot of question marks, is one way to try to formalize it, but there are still many question marks left. Thank you.
Dr. Ayala Rodriguez.
Thank you so much for coming and for the presentation. We really appreciate it. My question is in regards to equitable workloads and avoiding physician exploitation. So for example, in this particular cases, when physicians from abroad come, are there any requirements in other states about patient volume, for example, specifically during the initial probationary period? Because I think that even though they could receive same benefits, same salary, sometimes like patient load is like something like very undetermined.
That's a great question. There are not, to be blunt. Having said that, one of the requirements is that the supervisory physicians should be not only physicians, but they should be in the same specialty. So there's an understanding of what is typically expected in that particular medical or surgical specialty. And the other big question mark is individuals coming through these pathways, they're not resident physicians. They're not attending physicians. They're somewhere in between. How do you even figure out how much they should be compensated? What are they? They're not trainees. Are they employees? If they're employees, are they eligible for benefits? How much should they be paid? How much benefit should they have? Should they have on-call rooms? I mean, there are lots of questions that will need to be figured out. None of the legislation goes into that detail, which is why it's important for the states to share their experiences so that we can make some recommendations also.
I would also highlight that's the importance of defining who is an appropriate employer, because you want to make sure that however it is you define that for that reason, you're not including the potential for physicians to be taken advantage of in different kinds of practice settings.
Dr. Thorpe.
Yeah, I see well, clearly we have issues with underserved populations and the challenges seem somewhat daunting, because these very things that we've just raised, these questions that have been raised by my colleagues, who's going to monitor that? How does that get adjudicated? How do we know that, for instance, if we allow FQHCs to do this, there are chains of FQHCs throughout our state. Really, we're going to just turn these people loose in those places and expect them to supervise and monitor and not overload them with work? And are we going to be sending our investigators out to look and see what they're doing? Are we going to set the policies for that? There's a lot of, anyway, it's also interesting that there's only 2 people in the pipeline. So it's like, I don't know how big a problem this is going to be, but I think it is, as evidenced by the fact that so many states have adopted this approach, it just speaks to the great need in the workforce. So I wonder what your thoughts are about how do we ensure that these people are actually quality people that are going to be integrated into the culture of the communities that they work?
So that's a great question, Dr. Thorpe. And part of, I think we're all pleased and relieved, you might even say, that all of the states that are going down these pathways are requiring a period of provisional supervisory licensure. In some states, like Massachusetts, they've even said, if you need to repeat those 2 to 3 years, please go ahead and do so. Don't feel pressured to sort of give them a full and unrestricted license if they need maybe more time. But at the end of the day, there's going to have to be some details about that. The state boards don't have a lot of the resources to monitor these things, and yet they're going to be asked to issue a license to practice medicine, an unrestricted license. So there has to be a level of trust there, number one, with the employer. Number two, one of the reasons things like ECFMG certification requiring all 3 steps of the USMLE, the reason the states already put that in there in the statutes is they are independent, they are third-party services and products that all other physicians are required to take. And yes, it may be challenging or daunting for some internationally trained physicians after many years to have to take those licensing exams, but it's one effort, is what one of the states told us, to make sure that there's a level playing field. But at the end of the day, this has to be done thoughtfully, and I'm glad that states are actually doing this slowly and thoughtfully and looking to see what emerges as a best practice.
Other questions?
Yeah.
Dr. Solis?
Thank you for the presentation. My question was, does FSMB, in their guidelines that's going to be released, have suggestions about the retention piece? You mentioned it's one thing to recruit, but the retention's another thing. And because I often see programs, medical schools, residencies where, they set up in underserved areas, but it's that retention piece. And sometimes or organizations try to recruit students from the area to have them, with the goal of having them come back and return after their training. So just wanted to see if you had suggestions on that, or thank you.
Great question, Dr. Solis. We don't have specific recommendations. I think the profession has struggled to address that issue, and states have struggled, frankly, to look at that issue as well, because it's not just about pay. It's also about, if you think about young physicians who are happy to maybe, for the right reason, serve in those communities, they also are looking to their future and their children and feeling comfortable in that suburban or rural setting. So it's an issue. It's a much bigger issue. We're happy to partner with others to try to figure those issues out, but they're not easy.
Mr. Watkins?
I was just going to add
Oh,
one
excuse me.
additional thing. I'm sorry.
Sorry,
just
go ahead.
The importance of the data collection, because I think if we understand in what jurisdictions this is working, retention is actually one of the data elements that we suggest. So if we can understand where there are physicians staying, then we can look deeper into what those requirements were, what are the elements of those jurisdictions that we can then perhaps learn from and pass along to others.
Mr. Watkins?
Yeah, and I am very grateful for this presentation. It's kind of interesting because I spent a lot of time around a bunch of foreign doctors in South Africa recently, and their dream is to come and practice medicine in the US. And many discussions. So this is timely when I read it in preparation of this. My question was, I saw on this advisory committee that there's a cultural element that is present and a big hurdle. Like the Mexico pilot project, it's a plug-in to the Latino culture in California, for example. But in many other jurisdictions, you will have something different. So my question is, we currently have partnership arrangements, I'm sure, with American universities and some in Canada, English-speaking universities. And I'm just wondering what the approach would be. I'm just thinking like if the California, if the executive officer has an alliance, or we, the board, has an alliance with a South African or other countries, but they quote unquote top universities, and we make this available and say, hey, this is the criteria, then we can actually get it at the front of the quote unquote supply chain. And then that will stop us from having to do all this, not all of it, but it's a more smooth, a bridge program. And I'm just thinking that this is really good. And, I'm glad somebody started it, because I think there's going to be a lot of competition for skills in this space on the world stage, and we better get a cohesive game plan together.
Well, thank you. You've raised a couple of good points. Let me, in the interest of time, try to answer it this way. On the culture piece, you're absolutely right. And the provisional licensure supervision period is not simply to make sure they know the knowledge and skills. It's to help them understand the culture of the community they're serving and to make sure that there's a fit there. But also beyond that, it's trying to understand the American healthcare system. It's quite different than in other parts of the world. Understanding an electronic medical record, understanding Medicare, Medicaid, assistance programs. It takes time for even U.S. medical school graduates to understand that. And so that's also assumed to be part of this process, because I think there's some anxiety about if the process is rushed too much, that you may end up with physicians who are qualified but not able to practice. The other piece I'll quickly mention, you didn't mention it, but is the issue of specialty certification. If you're a surgeon, let's say, and you go through this pathway, this is only about licensure. So yeah, you get a license to practice medicine. Are you going to be able to practice surgery if you're not recognized as a board certified physician? The American Board of Medical Specialties has told the Advisory Commission that they have a task force that is exploring this. What they've said thus far is it's possible that some physicians who have gone through these pathways could be eligible to sit for specialty certification examinations. We don't control that. That's up to the specialty certification boards, but that probably could be helpful, because then, if, for instance, if you came in as a urologist and you did well in your supervisory period and you got licensed to practice medicine, but you can't really practice urology, primary care and family medicine is not a default specialty. Doesn't mean, well, all right, we'll let you do family medicine instead. That's a specialty of its own. And so I think those are additional questions that need to be sorted out, which is why getting data collection is going to be important. So we'll have more to share in the future, but I'm happy to share with you sort of where the states are right now.
Other comments, questions? I guess just one from me, which is sort of a comment. infused with a question, I suppose. I think that, given that there are now 18 states and potentially others that are considering these pathways, and then the fact also that there are apparently only 2 physicians that are in these pathways. I mean, it's just signifying that we all have a problem we're trying to solve for, right? Which is a physician shortage that either exists today or we know is coming at some point in the future. And so the question is, where are the other workforce opportunities? Because there's, I mean, for a variety of reasons, the immigration uncertainty perhaps today being at the top of the list is the reasons why physicians aren't considering this pathway. But where are the other workforce opportunities? And that, of course, could probably be a presentation, a task force, a commission in and of itself. But I think we should be thinking about this holistically, not just one pathway or another.
I would agree, Ms. Lawson. As you may know, and as I'm sure this board knows, across the country, there have been more medical schools starting than ever before, both MD and DO schools. Many schools have also increased their class sizes. One limitation has been federal funding for graduate medical education positions, but there are a number of pieces of legislation trying to expand that so that more of our U.S. graduates can do those kinds of residency trainings. So you're absolutely right. This is not the only pathway. There are many ways in which this can be put together. California's program with Mexico is an example of a success story, one might say. So we need to explore what works, figure out how to do this, and then I'm sure states will be interested because we have a nationwide shortage of as many as 86,000 physicians over the next 20 years. If you look at both HRSA data as well as from the Association of American Medical Colleges.
Thank you. Other questions or comments before we open it up to the public to weigh in? All right, thank you both. Are there any public commenters in the room? All right, seeing none, Sean, do you want to open it up online?
Yes, if you'd like to make a public comment on agenda item 13 here, please do so by raising your hand or typing something into that Q&A window. First up here, we have Rob Gordon. Rob, you should be receiving a prompt on your end.
Good morning. Test, can you hear me?
We can, please go ahead.
Yeah, my name is Rob Gordon. I'm a technology project manager here in San Diego. Most of those are community engagement projects. And to survive, I also have for financial, whatever. I also have an online store, Baja Sierra Trading Company. Years ago, I was a program manager in Silicon Valley, at one time having 25 project managers reporting directly to me. That was during the dot-com boom. And that was a H-1B visa program, which is a horrible program. It's an indentured servitude, essentially. So right off the bat is we got rid of that 100 years ago. So the fact that you kind of sailed by that, that needs to be mentioned, especially for this particular board, which really has a history of anti-American beliefs and attitudes. I also want to say that yesterday, Ms. Terry Webb, I'm an opponent of the Medical Board of California. I tried for 5 years. My successful mental health criminal program got criminalized by Family Health Care Centers of San Diego, which is a federally qualified health center here in San Diego. I believe it's a criminal enterprise, essentially. They just do really horrible things. And a man that fraudulently claimed he was my psychiatrist.
Mr. Gordon, excuse me, but do you have comments directed toward the FSMB?
Absolutely, I do. Is this Terry? Absolutely, I have. And you stopped me yesterday from talking. And I need to address that. That is now more important. I want my time put back on the clock.
I think unless you can direct your comments
I have
toward the
I am
FSMB
directly addressing.
Okay, that's
I have direct experience. I have more experience.
At this time, there's no additional requests in queue.
Apologies for that, everyone. We will bring it back to the board. Are there any final comments or questions? Okay, seeing none, thank you again. Thank you for taking the time to be with us and As I mentioned, for other members of the board, especially the brand new members, I've had the opportunity to serve on FSMB subcommittees and participate in their annual conferences. And I know that we all, as part of our board service, receive their publications, et cetera. It's just been a wealth of resources, I think, for our staff, for our board, for me personally. And so I just encourage you to consider getting more involved as you continue your service. And again, thanks to both of you for making the time to be here with us today. Speaking of pathways, we're going to move on to our agenda item 14, which is a presentation on the final report on the licensed physicians from the Mexico pilot program. And I think Dr. Sergio Aguilar-Gaxiola is joining us via WebEx. Is he ready to go? Great. Welcome, Doctor. We're pleased to have you here with us again to present the final report on the Mexico pilot program. As those of you who've been with us before for Dr. Aguilar-Gaxiola's reports, you know that he's the founding director of the Center for Reducing Health Disparities at the UC Davis School of Medicine. And again, we sincerely appreciate you joining us today, and we are very much looking forward to hearing your report.
Thank you so much, President Lawson. And it's a pleasure to be with all of you to do what I think that is the fourth presentation related to the licensed physicians from Mexico pilot program. So let me share my screen so I can bring the presentation to you. Let me just make sure that I have it. That is, and it's ready to go, but let me just make sure. I want to thank all of you for this opportunity to present the final report, kind of an overview of the final report. And I would like to just provide a little bit of background before I start with the slides. And that is that these Latino physicians from Mexico pilot program is a result of the Assembly Bill 1045 that was approved by the then governor back in 2002. And just very briefly, in California for 3 years, actually, instead of 30 that were approved, 27 licensed physicians from Mexico had been allowed to practice in nonprofit community health centers in medically underserved areas, as I will illustrate with in my presentation. And the LPMPP project attempts to address a national physician shortage, and certainly that happens in California, as I will address that, with qualified doctors from Mexico that meet the cultural and linguistic needs of California's underserved Latino community in California. And taking advantage of a report that was just published a few days ago, which is the California Physicians Edition 2025, published as part of the Almanac series from the California Healthcare Foundation. And the author is someone that you are familiar with, is Dr. Janet Kaufman from UC San Francisco. Just to illustrate the importance of a program like the Latino physicians from Mexico and the pilot project that I'm talking about. And just to make a comparison, these are number of physicians per 100,000 population. As you can see on your left, these are estimates by the Association for American Medical Colleges at the national level. And you see there the number of MDs and it includes DOs as well. And compared to what happens in the US, which is these two graphics, and California, as you can see here, the numbers that you coming from the medical board in 2023 is that the number of primary care physicians is just at the threshold of the recommended PCP supply. So there is a shortage in California compared to the nation as well. It's important to consider that as part of the context that I want to provide you with. We have been evaluating the efforts of this LPMPP program in 4 counties in which there is a law, very low in San Benito County, for example, to low concentration of PCPs. And as you can see there in the Salinas Valley in Monterey County, San Benito, as I mentioned, Tulare County, and also Los Angeles. And just to give you a little bit more information, these are the primary care physicians and specialists by region with the latest information available, which is 2023. And what we have here is there is in the San Joaquin Valley, it is below the recommended PCP supply, as well as the Central Coast, as well as Los Angeles. Los Angeles is in the threshold. Of course, there are others like Inland Empire, which are very low concentration of primary care physicians that we need to consider as well. These are, and I want to highlight psychiatrists because I have spoken, for example, with Dr. Max Cuevas, the CEO of the Clínicas de Salud del Valle de Salinas, who is one of the participating community health centers, FQHC, and he tells me the tremendous need that they have for psychiatrists. And I'm a researcher. As President Lawson mentioned, I'm the founder and director of the Center for Reducing Health Disparities. And we have been documenting precisely disparities in access to health and mental health care. And there are tremendous gaps, treatment gaps in California. So I want just to bring to your attention once again the number of psychiatrists per 100,000 population in the San Joaquin Valley, which is very low. Central Coast and Los Angeles County, low compared to what's happening in the San Diego area and the greater, certainly greater Bay Area. This is also something that is important to bring to your attention. I know that I have presented some of this in the past, and so it's nothing new, but this is the latest numbers. If we consider the active patient care of MDs in 2023, there are only 6% of them are Latino. And this is compared to the total California population, which is 40% back in 2022. This is even a greater disparity right now. And I'm not highlighting the California Medical School graduates, which is about 9%. I'm quite familiar of the proportion of Latino and other medical school graduates at UC Davis, and we really have been striving to increase the number of qualified graduates as well. This is Latino physicians and population by region, and this is in relationship to the population. As you can see, tremendous disparities in the proportion of Latino PCPs in the San Joaquin Valley, Los Angeles County, and the Central Coast in relationship to their proportion in the region as well, the proportion in the population. These are the medical school graduates. I was very interesting to see how we had been collectively increasing medical school graduates in the last 20 years or so. And unfortunately, from 2021 to 2023, there was a decrease in the medical school graduates, as you can see here. So it is important to consider this as a context to the LPMPP project that we have been evaluating in the last 4 years. One thing that I want to emphasize is that this is the evaluation that we did in basically 6 outcomes that were identified by the California Medical Board. And you see them there, from 1 to 6. This is well documented, by the way, in the final report that is part of the package for this meeting. And also, you ask us to provide recommendations on whether the program should be continued, expanded, altered, or terminated. So just to give a little bit of context as well, we organize the outcome measures by these 4 different areas. Patient outcomes, that includes quality of care, and response and approval by patients. This is, we refer to as patient experience. Also, physician outcomes refers to the adaptability of the physicians from Mexico. Also, the organization and clinical outcomes, and there are 3 items there, as you can see. Impact on working and administrative environment and interpersonal relations with their medical license counterparts in the health centers. Also, the impact on cultural and linguistically appropriate services, and the impact on limited English-speaking patient encounters. And finally, the recommendations, as I mentioned. This is the conceptual model. I won't spend too much time here, but this is just how we are linking the outcomes with the specific instruments, like the 3 main outcomes, like organizational and clinical outcomes, physician outcomes, and patient outcomes. And this is another way of looking at the evaluation. This is the framework that we use. So we have patient outcomes, physician outcomes, and then the organizational and clinical outcomes. And you see which are the measures that we use, the specific instruments that we also use, and the time frame that we follow to do the evaluation. As I mentioned previously, there are 27 physicians from Mexico, PCPs from Mexico that participated in this stage of the project. And as you can see, the numbers, clinical, de Salud del Valle de Salinas is the community health center network that had the most number of physicians, for a total of 27. We have published, by the way, 5 comprehensive 4 progress reports, and then the final report that we submitted at the end of March of this year. So in terms of patients' outcomes, I want to share that in terms of quality of care, that the UDS data demonstrates significant demonstrating significant increases in the detection and treatment of chronic conditions, particularly in diabetes and hypertension. You have some specific numbers that we saw almost doubling between 21 and 23. Also, chart reviews, which we did, indicated high rates of concordant care with clinical guidelines, and the LPMPP physicians were praised for patient follow-up, contributing to reduced emergency room usage, as well as other important outcomes. And I included a couple of quotes because the final report, we focused primarily, although not exclusively, on the qualitative outcomes because we had a very robust qualitative assessment of the evaluation as well. So the first quote, these doctors bring in a quality, great quality care for their patients and their knowledge. Also, the LPPM physicians take the time to care for the whole patient and their needs, not just the issue they came in for, but if they notice something else, they address it during the same appointment coming from a patient. This is a response and approval by patients. This is related to the patient's experience, that there is a patient satisfaction that improve across all clinics. And I have a little bit more information related to the cultural linguistic concordance. Also, patients felt more confident and comfortable navigating the healthcare system, and interpreter use decreased. Two quotes that I'm including there, and you'll find these quotes in the final report, by the way. One quote from a patient: since the doctors had been here, there has been a significant difference between because they teach us, the patients, educate us and explain these illnesses that were not explained to us before. They love, and this from administrator, they love seeing the patients, and so far, we've learned that the patients love them. They are able to connect to them on a different level than the providers that are raised and trained here. In terms of the physicians' outcomes, and this related to the adaptability of the physicians, the physicians from Mexico adapted to clinical guidelines and EMR so quickly, and also many served as informal mentors and participated in team-based care models. But one thing that is important to highlight, and that is that there was emotional distress noted in the Mexican physicians, including fatigue and burnout. This is related to the workload and the cultural adaptation challenges. So I have included a couple of quotes here. One by an administrator. They are providing not only a care that's consistent with our standards, but they are adapting to the setting well. They are being integrated within the team and the patients. And this is from a non-LPMMP provider, their counterparts. He is getting better as time goes by, but it's been a little bit slower with him. Again, in respect to knowledge, quality of work, and bedside manners, it's been really good. These are the organizational and clinical outcomes related to administrative and working environments. There was the observation that from staff that there was an improved teamwork, mutual respect and communication among clinic teams since the physicians from Mexico started. Some staff noted declines, a little bit of declines in job satisfaction, potentially linked to increased patient load and onboarding stress as well. Two quotes included there by administrators. Everybody's been very happy, very happy and accepting and welcoming too of the new providers. Financially, it's expensive because we pay for all the immigration fees, and we also have to start paying them their doctor's salary, wages, and there's no revenue because they can see patients. But I'm sure it'll even out at the end of the day once it all gets taken care of. And this is a provider we don't have and we have been struggling to fill. This is related to the delivery of cultural linguistically appropriate services. The LPMPP physicians help clinics meet the class standards. The class, just as a refresher, refers to the cultural linguistically appropriate services standards and is related, as is indicated, on cultural linguistically competent care. Patients and administrators highlighted the reduction in cultural misunderstandings and increased trust. And I'm included a couple of quotes. Once again, one from an administrator and one from a staff. We have a great population of Hispanic, Spanish only speaking patients. They really appreciate having somebody who can speak Spanish directly to them, not having to relying on their sometimes not very efficient English or relying on the kids to translate to them. It's been really great. They speak Spanish directly to a lot of our patients. It's just been great. The other one is most of the time we have a translator, interpreter, or the provider uses a translator. I feel like the patients are really okay, or they don't think we're understanding them. As where the provider speaks Spanish, they can speak to the patient face to face and explain to them. I think that these quotes are illustrative, once again, of the points that I'm trying to get across in the slides. This is another one, encounters by limited English proficiency patients. LPMPP physicians increase clinic capacity to serve Spanish-speaking patients without delay. And both the staff and patients reported fewer miscommunications and increased adherence to treatment plans. Once again, a couple of quotes to illustrate these points, one by a patient and the other one by a non-LPMPP provider. The patient, I think it's important that the providers, speak our language because they bring an interpreter or a nurse, but then you hold back more. Whereas when your doctor speaks your language, you speak directly to them, and it's no longer like there's a third person there. This is from the non-LPMPP provider. It's such a benefit to have the doctors, the LPMPP physicians, there to be able to communicate with the patients smoothly, cleanly for the patients, for them to be able to express themselves smoothly and cleanly and not to have to dance around words. So these are the recommendations that we included in our final report. This is just a very, very summarized rendition of what the recommendations are. And we are strongly recommending for continuation and expansion. A couple of points. Multiple stakeholders strongly supported program continuation, citing increased access, quality care, and community trust. And also, it was captured on the qualitative assessment that we did, that the loss of the program was seen as a major threat to quality care delivery for Spanish-speaking populations. I included a couple of quotes from patients. Personally, we would feel anger when the LPPM program is taken away from us. And many times people would say, I'm not going to the clinic anymore. But I think in terms of the community, there would be a stronger impact, like disempowerment, like when you are given a candy and then it's taken away. The quality of care would decrease overall. The other patient, it would be a disaster if the program was terminated because we truly need it. It's a need. It's a personal need. It's a community need. It's a necessity. This is related to program improvement and sustainability. And what the program is doing is to increase the program, the importance about increasing program awareness, optimize physician balance, that is of critical importance to consider, and also extend the program duration. I have a few slides, 3 slides related to the program improvement and sustainability. This is the second. Expand provider specialties and capacity, grow the LP-MPP cohort sizes, and include more in-demand specialties like psychiatry to improve access, strengthen fairly qualified health center collaboration and partnerships, and enhance partnership with Mexican institutions as part of the recommendations. This is the next to last one. More recommendations to implement phase strategies, use phase rollout to reduce clinic disruption and support smooth physician onboarding. Also provide mental health and wellness support. This is important based on the qualitative outcomes that we have doing focus groups and in-depth interviews, and also enhance onboarding and integration. This is going to be helpful to ease the U.S. transition for the physicians coming from Mexico. This is my last slide. I want to, on behalf of my team that have worked on this evaluation for the last 4 years, and it's been a real pleasure to be working with the Medical Board of California, but to thank the leadership, their teams and patients from Altamed Health Services, Altura Centers for Health, Clínica de Salud del Valle de Salinas, San Benito Health Foundation, who really collaborated and participated and cooperated with us to make this evaluation possible. I cannot speak high enough of the medical board staff with whom we work with Reggie Bargisi, Marina O'Connor, Carrie Webb, Douglas Huck, and Dora Duran Franco, and our staff who work on this particular evaluation. I cannot thank enough Andrea Nunez, our CAO, Iman Sahid, Jill Lopez-Raven, who worked with all of you along with Iman, Dr. Miriam Nuño, who helped tremendously with the analysis, and also Yuri Garcia, who also worked with us on the analysis as well. So I'm going to stop the presentation, and I'll be more than happy to answer some of the questions that you may have. And once again, thank you so much for the opportunity to present for 4 straight years about the progress of the evaluation. And I'm delighted that we were able to jointly complete this project.
Dr. Aguilar-Gaxiola, thank you to you and your team for all of the work that you put into this project and for taking the time this morning to present your report to the board. Are there any questions or comments from board members to start? Dr. Ayala Rodriguez, please.
Good morning, Dr. Sergio Aguilar Gagiola. Thank you so much for the
Dr. Ayala.
presentation. Very exciting data. I was looking at the 2024 data actually from HRSA because it just got released like within a month, and it continues to show improvement. So that is great. Like look at San Benito, and it's like continuous improvement in quality of care. One of the questions that I'm going to have, it's like, what's going to happen next in terms of the supervision of the performance of the program? Is that something that it's going to be hand off to the individual institutions, or what's going to happen? But also, I wanted to clarify a point in one of the statements that Dr. Aguilar Gagiola submitted. It was, I want to assume, an OB-GYN. Because I'm quoting, like the physician says, I'm losing my surgical skills. I cannot be here 3 years without doing any surgery at all, when the hospital didn't approve, I guess, the privileges. So that tells me that some of the OB-GYNs in this particular program like try to obtain privileges at the hospital, right? And my understanding of the program is that they are restricted to medically underserved areas. They are restricted to federally qualified health centers, but not necessarily to the scope of practice, right? As long as they are in a medically underserved area and in a federally qualified health center, right? So, because just based on that statement, because they are already trying to credential or privilege an OB-GYN physician at a hospital. Question to clarify that scope, because if the intent of the program is to support underserved areas and to support federally qualified health centers, do have a broad spectrum of scope of care. Some of them do urgent care, some of them do hospital care, some of them do PACE, some of them do ECM, ACOs, typical outpatient. Is all of that included? Because if that is, then to a certain degree, we should support the communication or the clarification of the information so hospitals understand about the program, because there might be the need for a proctoring process or for a training phase or things like that. But if hospitals do not understand the program or the licensing or the requirements, then I do see that as a continuous struggle that OB-GYNs physicians like will deliver. And yes, they might be seeing patients outpatient, but the patients still need someone to deliver them at the hospital or to help augment the OB-GYN physicians at the hospital. So I think that in there could be an area of opportunity.
Thank you, Dr. Aguilar-Gagiola. I didn't know if you had anything in response.
Just a couple of comments. Well, thank you, Dr. Ayala, for those very excellent points, good points. One is in terms of what's going to happen with the oversight of the continuation of this program. We haven't been privy to that, so I won't be able to answer that. I think that it's important to have oversight, but we haven't been involved in those discussions. In terms of what the other excellent point that you made, it is really related to what Dr. Chaudhry in the previous presentation, excellent presentation that he made, the specific point that he made about the limitations, and that is something that I think that is going to be of critical importance that you discuss and see, how you can. I mean, the medical board discusses, you are the maximum authority on this, and see, if you consider that that could be an extra important service, especially in these way underserved areas, that you do something about it. You are doing a lot, and I totally recognize the incredible commitment that you have to provide access to timely quality care for the populations that are being served in California. But I will leave it out to you as well.
Thank you. Other questions, comments? Dr. Yip?
Thank you for your presentation, leadership, and commitment to make this successful program. Love to hear from you again in the next year too. Thank you.
Thank you.
Thanks. Dr. Solis?
Thank you for the presentation. As a physician that practices in the Central Valley, as you mentioned, the shortage of healthcare providers makes it difficult for patients to access care in a timely manner. So this project, this pilot project really appears to be an innovative solution for those healthcare shortages. For me, my question was, when I was reading the report, it mentioned that there were some issues with documentation and, well, charting, just that there's a need for more standardization. So I think in one of the recommendations, you mentioned about the onboarding process. And yesterday we heard a presentation from UC San Diego's PACE program, how they help physicians with charting and prescription management and so forth. So for me, I was thinking with the onboarding process, instead of starting from scratch, collaborating with existing organizations that are doing a good job at that standardization process. So it was more a suggestion since we heard that great presentation yesterday at the board meeting. But yes, thank you for producing a very thorough report.
Well, thank you, Dr. Solis. I'm very glad to hear from you. And that you are a part of the board, the medical board, representing the Central Valley. And thank you for that very keen observation that you made. And I didn't listen to the presentation yesterday, but you piqued my interest. I would love to see what was presented to you, because indeed the LPNPP physicians that we work with, there were some issues related to the onboarding that can be smooth. And it makes a lot of sense to learn from other initiatives as well. So I'll be looking for those recommendations from what was presented yesterday. But thank you for your kind comment.
Other comments or questions from board members? Okay, let's open it up to the public for comments or questions. Anyone in the room? How about online, Sean?
Yes, if anyone would like to make a public comment on agenda item 14 here, please do so by raising your hand or typing anything into that Q&A window there. First up here, we have Rob Gordon.
Hi, my name is Rob Gordon. I am in favor of this program, as I was in favor of the previous program. There were some nuances I wanted to express that had to do with protecting some of your physicians from abuse. I have experience with all the things you're talking about, the H-1B visa program, the federally qualified health centers, and psychiatrists. And there's some important nuances. It's been made clear to me that I am not allowed to express opinions here, so I won't be doing that. I do, however, want to encourage physicians to sue to sue the Medical Board of California. Terry Webb escalated a dispute we had, and so that is what I will encourage you to do. This organization is already in a death spiral. You've made a fool of the Attorney General's office multiple times, and this is a failed program. This has been a failed meeting here in San Diego. And, you have flown more people down to San Diego than you have audience members. I haven't seen a great deal of community engagement, so this has been a failed meeting. I just hope you go home. We're supposed to have basic freedoms in this country. You've denied them. I agree with a lot of things that have previously been said about this, but I do believe you're doing a good job. It looks like you've done a lot of hard work. We thank you for that. Some minor nuanced things I wanted to express, I am not allowed to express them here. So I will be working for the next 3 years. That's how long the Medical Board of California took away my most basic rights and freedoms, and it has been escalated. I can always escalate, and I will be responding, probably this time with a 3-year program to encourage physicians to file lawsuits against the Medical Board of California if your rights have been violated in any way. Thank you. Let other people speak.
Thank you for your public comment. If anyone else would like to make a public comment, please raise your hand or type something in that Q&A window. See if there's any more requests in the next few seconds. I'm not seeing any additional requests.
Thanks, Sean. We'll bring it back to the board. I think Ms. Webb, you had a follow-up to Dr. Ayala Rodriguez.
Yes, I just wanted to respond to your questions about supervision, and the supervision will be provided by the clinics who employ these physicians. There is a secondary level of peer review that takes place, and UC San Francisco will be providing that service under the code. As far as I'm aware, none of the physicians that have received this license, the 27 physicians have received hospital privileges. And this is a similar issue to what Dr. Chaudhry was talking about. That can be a significant barrier to the types of care that they'll be able to provide. But as far as working in the clinics, we've heard from the patients, their colleagues, administrators, and other staff that they're providing a great service.
Any follow-up questions before we move on?
President Lawson,
Yes.
Can I just mention how grateful I am to Sean for the assistance that he provided to get ready for the presentation. I'm not that familiar with WebEx, but he helped me tremendously navigate. And I'm delighted that I didn't encounter any difficulties thanks to the excellent assistance that I got from Sean.
Thank you. We are all grateful for Sean, and that is a great segue into our moving on to agenda item 15, which is Sean's show, a presentation on the complaint tracking system. We'll turn it over to you, Sean.
Thank you very much, Doctor. I'll go ahead and move you back to attendee now.
Okay.
Okay. Talk in the microphone like I remind you guys to do all the time. Let me get a slideshow up here, and then I might have to make it a little bit bigger on the screen behind us. Okay, let me switch that. Sorry. Sure, this computer, but that's the one presenting and it's not coming up. He jinxed me. Sorry. I have to leave and rejoin the meeting here.
Why don't we take a 5-minute break? We'll let him get set up and we'll be back. No problem. Sean, let's get back up online and get going again.
We're back online. Thank you so much.
Great.
Apologies, live demos never go the way you planned. I have to share from over here, so apologies for being behind the camera and everything like that. But wanted to start off recapping presentation that we gave last time, just to go over how we got to this part for the new board members and to remind all the existing board members how we've led up to this. So here I've got the slide up, and then we will jump to the demo next. But before we get to the demo, we'll spend a few minutes here just through these slides. Just a background for those not familiar with Breeze yet. It has been possible in Breeze since its launch in 2013 to submit complaints online. But once you submit that complaint, kind of goes into a black box in Breeze in terms of getting any updates from Breeze or anything like that. You're reliant on paper letters sent by the complaint unit or contact with the complaint unit through phone or like I said, paper letters and some emails and things like that. So back in 2021, we dreamt up conceived a project to build a interface so that people could go in there and look at their complaint status and see what's going on through it as it progresses through its life cycle. Because it's a public-facing application, we're required by the State Information Management Manual, we call it SIM. It has a project approval lifecycle process that we had to follow and work with the Department of Consumer Affairs through that. First part of that is to come up with the objectives that you want for the system. So the objectives, when we originally dreamt this up, the objectives we were looking to meet were to increase visibility for the patient or authorized representative on the progression of the complaints they have submitted to the board, provide status of complaints faster than traditional paper letters sent through postal mail, provide information outside of traditional business hours. That's when like our call center is operating from 8 to 5. This way people are busy at work during the day can get the status in the middle of the night if they choose to. And then, side benefit would be to reduce enforcement staff time spent on routinely answering case inquiries so that they can more efficiently spend time processing complaints instead of just providing those updates as they come in every day. We held 2 interested parties meetings as part of the planning for this. So after those original objectives were set, we held these 2 interested party meetings, one on March 6, 2023, and the second on June 21st, 2023, where we provided a dedicated and extended opportunity for public comment on the presentation that was originally given at the May 2022 board meeting. This would allow the public to provide suggestions and request additional functionality for the proposed system. Prior board members, Ms. Lubiano and Dr. Bolot had attended those meetings, providing suggestions of their own and assisted in taking public comments and documenting the suggestions. The recordings of those interested party meetings are available on our website if you're interested in going back and reviewing any of them. 27 suggestions were documented in total over those 2 meetings, some from Ms. Lubiano and Dr. Bolot themselves and the rest from the public attendees. Each suggestion was captured in a tracking list, which was published and discussed as agenda item 14 during the December 1st, 2023 board meeting. All the suggestions were reviewed for technical and legal feasibility. Many of the suggestions have been implemented already, as you'll see in this demo, but several were determined to be outside of the scope of the complaint tracking system, either because there was a technical reason for accomplishing that request through another mechanism other than the complaint tracking system, or a legal reason why the request could not be fulfilled. Just to talk a little bit more about the project approval lifecycle, so you guys understand why we started dreaming this thing up in 2022 and we're just now getting around to implementing it. We had to define all of those requirements, put together a full business analysis documentation, submit that through the Department of Consumer Affairs, ultimately to CDT. For a project of this size with the public facing, because we weren't asking for extra funds, extra resources or anything like to do that. We were using our in-house programming staff to build this. We received delegated authority by the CIO there at DCA to proceed with the project. And by the time programmer resources freed up, we started development in early January of 2025. So what you'll be seeing here today is the development that's happened since then. It first started with pulling the data out of Breeze and then building the interface that I'll be showing you today. Before I go jumping into the demo, though, I want to just put out a few disclaimers here. So we'll be looking at some complaints and that have complainants and respondents that are made up by me. So they're, joke names, actor names, things like that. But so if there is anything that complaint numbers, anything like that, that are all fictional. This is all in a test environment, nothing relating to production stuff. I just want to make that clear. If anyone's trying to ask questions about these complaint numbers, they're all made up in my mind. So we did take into account realistic current enforcement activity coding standards. So the time frames and the order of things that you see in these complaints would follow along with how things are done today with current business processes. Some of the backdating and stuff like that may extend before some of these processes were in place, but it's just to give you an example of what a current complaint that goes forward. We won't be having complaints older than the current coding processes viewable in the complaint tracking system. Only open complaints and complaints submitted after a certain day once we decide to go live. So even though some of these dates will be backdated, they're following modern coding standards, if that makes sense. I'll also be showing you from a development environment, so it doesn't have quite the horsepower of the production systems and stuff like that. So we're going to see some loading times and things like that. But let me go ahead now and share with you another screen here. Okay, so I'll be utilizing a service called Mailinator. We use it for testing all the time. It's basically public mail inboxes so that I can simulate being a complainant of these complaints that I'll be pulling up for you. The way the complaint tracking system login works is that you will have your complaint number you receive when you submit a complaint. You receive an email, or you receive a letter mail right now with a complaint number that goes back to the address you provided when you submitted that complaint. By go live of the complaint tracking system, we hope to have in place an email version of that. So like right when you submit a complaint online, you'll get an email with your complaint number. And as long as you provided an email address when you submitted your complaint, you'll have immediate access into the complaint tracking system. So let me grab my first complaint example here. So the complainant will receive the complaint number, again, either through that paper letter or through an email, and then they will put in their email address here. Let me copy this so I don't type it wrong. And so I've, again, made up a complainant here. I'll be submitting my authentication. This captcha here, because it's the first time I'm doing it, it's letting me through. It'll probably ask me to pick some fire hydrants here in a minute or something like that, but we'll go ahead and say login, and that's going to generate a one-time passcode that will get sent to that email address. So it's two-factor authentication, like you're familiar with all kinds of applications nowadays. And so that complainant now will receive an email from the board, and if they scroll down into it, they will see they'll get a one-time security code. The language in this email, all that is still subject to change as well too. But the important part is this little 6-digit code that they come and they enter that 6-digit code into the system to prove they are the owner of that email address on the complaint. And they hit verify. The complaint then opens up in the system. This first example here that we're looking at is a complaint that was ultimately closed because it was unable to meet the burden of proof. But let's start out here with the header. The summary information, I hope that's big enough for all you guys. Let me turn this up a little bit. So again, made up complaint summary, but because I submitted this complaint online through our development system, the complaint summary comes in exactly how I entered it when I submitted the complaint. My complainant details, again, this is all made up information, but this email address is the authorized complainant email that is allowed to access the system. We see the fake doctor, that fake licensee that this complaint is about, the respondent information. And here we have a link to their DCA search profile. So you can see address information, the current status of their license, expiration dates, and all those things over there. And we'll see example of that here in a few minutes. And then we come down to the complaint activities. And so the first thing we saw up here was that this complaint is closed. Again, the styling, the text here, all subject to change. And I'll get more into that here later on. But the first indicator up here is this complaint is closed. And we come down here, we see there's 8 activities to be displayed. The first activity here is that the complaint was received January 16th of 2025. On January 21st, it was assigned to a central complaint unit analyst. And we see that that central complaint unit review was completed on June 25th. Now, this is just to give you an idea of how long that central complaint unit review took in general. Activities can happen concurrently as we're going through here. So we see that after January 21st, when it was assigned to the central complaint unit analyst, a request for a medical release was sent on February 6th to the patient or authorized representative. They await for that medical release to be signed and returned back to them, and they indicated that, yes, that was received on March 12th, 2025. After that activity was completed and they had the medical release, they were then able to request the records from the subject of the complaint since they had that release in hand. That began on March 14th, and it indicated here that the records were received from the subject of the complaint on April 17th of 2025. After the records were received, it was packaged up and sent to the medical consultant review desk to be assigned out to a medical consultant for review. The medical consultant's review was completed on May 28th. These timeframes, these are just approximate averages for these things, so they're realistic timeframes. But again, just these dates are all made up for the demo, but we tried to show you here what a realistic timeframe for all these activities would look like. After the medical consultant review was complete, it was referred to the complainant liaison unit. Too many little acronyms here. We're working on describing all of these different activities in as plain English as we can. We're going to be taking advantage of tooltips like this to explain keywords to help define that out. So some of these we've gotten through, some of them we're still working on, but we have tooltips and we have the ability to link out. I think like here, if you this one has a link out, so if you click here, it will open up a page on our website where you can read more about the complaint review process and things like that. So we can utilize kind of in-page definitions as well as external links out to our website or other sites as well. So it's referred to that complaint liaison unit there. We have a description of what an interview means essentially. And on June 2nd, that complaint liaison unit review began, and it was completed here on June 20th. So again, here is another concurrent process happening where we have, after the June 2nd referral to the central complaint, the complaint liaison unit, an interview was requested with the complainant by the complaint liaison unit, and they completed that interview on June 20th, and that was what triggered them to also be able to complete their review there on June 20th as well. So these activities have pairing end dates, and again, sometimes you have to kind of zoom out and take a look at them all. They're by sequential start date, but that doesn't mean something isn't concurrently happening down there below it. After that interview was completed by the complainant liaison unit, and the complainant liaison unit review was completed, the complaint was ultimately closed because we found that we were unable to meet the burden of proof for this particular complaint. If we go back up and we look at the summary, this was again just kind of AI generated helpful stuff, but essentially after the medical consultant review is ultimately determined, no further action was appropriate. So this is a complaint that has gone through the full process. Again, the ultimate closure reason will always be described down here below. And then at the bottom of the page, we have a form basically to fill out. So the complainant can get in touch with the analyst assigned. And in this case, the complaint is closed, it's no longer assigned, so there'll be a catch-all mailbox for these things. But if they enter in a subject line and a message, they have 500 characters, that limit can be increased or decreased. But they can send a message in to the complaint analyst that will receive that in their email mailbox. Eventually, we have a stretch goal to ultimately put that information right into Breeze for us. But at this time, all we can do is pull data out of Breeze. We can't put any data back into it yet. It would be up to the analyst to receive the mail, add that question and response into Breeze so we have it for ultimate tracking. So, so this is the example of a closed, unable to meet the burden of proof complaint here. I used the same complainant and the same licensee here to make a second complaint. Just let me find my complaint number there. Sorry, I see my messy workspace. Still doesn't think I'm a robot. Good. Sometimes I get caught in that loop for quite a while. So a new alert now, a new license or multi-factor authentication code comes through. I enter that in to log into the store. Every time you log in, this is like an example of a complainant that has multiple complaints active. Every different complaint number, they have to log in every time, get that multi-factor authentication code and enter that in there. So this is another complaint that, again, totally made up here, but this one we have still open. The complaint was regarding the doctor treated me earlier this year and diagnosed for a torn meniscus in the right knee. The doctor provided imaging and treatment plan for the meniscus tear. My ongoing knee pain persisted even after following the recommendations. Again, we see the complainant information. This time I intentionally left the complainant phone number empty here to show that if the complainant was reviewing this and they saw, hey, the board doesn't have my phone number and wants to be able to contact me by phone, it would be a good use of the contact us form down here at the bottom to just write an email and say, hey, my phone number is this. The analyst can add that to the complaint record, and then it would show up the next time after it's been added into the system. And we see again the licensee that this complaint is against. And then we scroll down now, we see we have 12 activities in this open complaint. Again, the complaint was received by the board, assigned to the central complaint unit. A review is completed, but we see some concurrent activities happening here. So a request for a medical release, again, usually happens in almost every case. This time records were requested from the hospital after that release was provided. The records were received from the hospital there on March 3rd, and then went to a medical consultant program for review. The review was completed here on April 11th, and after April 11th, it was referred to the central complaint. I don't know why I have so much trouble saying that. The complainant liaison unit again, and the complainant liaison unit began their review on April 18th. We see here it closed on May 7th, but we have some concurrent activities happening down here below on April 23rd. The complainant liaison unit there requested an interview. That interview then again was completed on May 7th. And in this example, in this situation, we're trying to illustrate that the complainant liaison unit, when they interviewed the complainant again, the complainant provided additional information indicating that for their knee issue, they went and saw a second practitioner and got a second opinion, basically. And based on that information being received now, the complainant liaison unit sends it back to the central complaint unit where additional records were requested from this other hospital to get this second opinion there done. And then that additional information now is sent back to the medical consultant review program to review now with both of the files. And after reviewing that second file and the information received, then the complaint unit was confident they had enough information that this justified being sent to HQIU for investigation. And so it gets referred to investigation here on July 8th, and basically gets assigned to an investigator on July 11th. Concurrent activities happening down here again. On July 8th, a complainant impact statement was requested by the Central Complaint Unit. Here we're indicating, even though we're in August, this probably would have been completed by now. But this date, this yellow color now here shows that there's an outcome still pending on this item. So we're trying to use colors right now. We're trying to stay away from any positive or negative connotation about greens and reds. So we're actually looking at what it might look like to use icons or something else to demonstrate there's something pending. But for right now, and for all of the prior wireframes and mock-ups I've shown you guys, we've used these green and yellow and red colors. So, but that yellow is basically there right now to tell the complainant, keep your eye on this one. The outcome of this will change. You know, the requested will eventually be replaced with either the complainant impact statement was received or that we ultimately got no response. And then when it's referred to investigation, at the time that it gets assigned to an actual investigator, we see here that it was assigned to an HQIU investigator as opposed to our complaint information office investigators. And that happened on July 11th, and that investigation there is still pending as well. So their ultimate notice when they log in to look at their complaint, they see basically here, hey, this complaint is still open. You know, one of the things we hear a lot is that complaints get closed, letters get sent, but letters ultimately take time to get delivered. The mail system is not perfect. Letters don't always get to the intended recipients all the time. So at any point now, a complainant can log in. They can see their complaint is closed, their complaint's open. We'll be adding more and more email triggers for events like these to ultimately, hopefully, replace that paper letter process. But we'll always have to have some sort of paper letter for those that don't provide email addresses and things like that. You can use your mic. Just for the.
Where's the yellow?
It is hard to see. It's a little washed out. I try to dim the lights here, but like this, the background of this as opposed to the white here, it's very faint differential there, but you can tell this activity is a different color than like the green one above. So these ones are yellow, and maybe if I scroll down here, you can see this is the white. So sorry, it's a little bright in this room, but so again, this here's a complaint that's still open. The complainant can still send messages in depending on who has the complaint. In this situation, the HQIU investigator would have the complaint. So the message would get routed to them via email. All right, and so then finally, I have one more complaint to show you, one that resulted in some discipline here. So let me pull up that example. And this is a different complainant and a different licensee as well too. Hey, 3 green check marks. It's a miracle. So I need to go to a different mailbox now, and I've gotten a new code, this again to a different fictional complainant. Get that security code to access that complaint. We set this at 3 minutes. Obviously for this demo, I've got everything ready and stuff like that, but we can play around with that time for how long that lasts and see what works best for users. If we need to bump that up to 5 minutes or something, I think that would be perfectly acceptable. This one is a formal complaint regarding the conduct of a doctor whose treatment resulted in serious harm and demonstrated a shocking lack of professional competence. Again, this is all just generated by AI, but we're looking to find an example that would result in discipline. So the complainant information here again we see is different, and this time against a different licensee. I'll be visiting this link here in just a second. Let me preload it, in fact, because I know that'll take a second to come up. But we see 10 activities shown here. Again, this one that we've backdated now to give you realistic timeframes. So while it is backdated, it's following current coding standards and things like that, but we just want to show realistic timeframes for y'all. So complaint was received on April 30th of 2022. assigned to the Central Complaint Unit May 8th, August 22nd, when they completed their review. During that time, they again requested the medical release, received that. They sent to the medical consultant program for review. Medical consultant program forwarded it on, referred it to investigation on August 22nd. It was assigned to investigator on September 5th. We see here that assigned to the HQIU investigator on September 5th, and then their field investigation ran through January 27th of 2024. The thing we wanted to point out, illustrate here is during the confidential HQIU investigation, there isn't a lot of activities. The investigation's being done in the field, and so there's no information really we can share during that time. We do know that the investigation, though, completed on January 27th of 2024, and all of the information that field investigators gathered was packaged up and sent back to the board to review for case disposition. When it was reviewed, since this was kind of an egregious case, I believe, as we were setting it up to be, it very quickly was referred to the Office of the Attorney General for filing of an accusation. And so it's sent over there on January 28th, 2024, and accepted by them on March 8th of 2024. The accusation gets put together and ultimately filed on May 25th of 2024. And then we see ultimately that on July 14th, 2025, the case was closed, indicating that the license has been revoked. We have, again, these links out to all these, different places to read about the disciplinary process more and stuff, because you can picture as this thing is going and it's building, the complainant might have questions and they can go out and read those resources before they ultimately, ask us any questions. But once this case closed, revocation activity code comes on here. We say, click the respondent's license number above to view the license profile and any related documents. So in this example I set up for you, I clicked that a second ago just to speed up the load time, because this is again going to a test environment of the DCA search system. I can try to make that a little easier for you guys to read, but so again, this is a made-up license in our test environment, so not all of the documents and things are there, but what we can see is here that the license was revoked. Just the same functionality of the DCA search license lookup system now will tell the individual that the status of this license here is revoked. The expiration date doesn't show on a revoked license anymore. Ultimately, in a real example, we would see here something here under the administrative disciplinary action section, where that order about that revocation information was posted. And then down here, we would also see a public document, which would be that order itself posted. Wasn't able to fake those parts for you. But so the license status itself isn't shown in the complaint tracking system, is ultimately what I'm trying to show you guys here. It just would give them indication that the complaint was closed for revocation. You want to see what happened to the license? We have an interface for that, the DCA search system. Go over there and check it out, and that's where you can get even more information over there. So those are the 3 complaint examples that we prepared for you. I hope you get a feeling for how you get that security code, you log in. Let me go, before I take questions, let me, I have one more slide. So this is our phase 1, we call it the minimum viable product that we could put together, having the resources we have with out doing a lot of these stretch goals that we eventually want to do. The first one there for or these enhancements that we like to make in the future are again after the first release, which again we're targeting for the end of this year, beginning of next year. We want to have more automatic email notifications when a complaint is initiated or a configured element is updated. So Again, by go live, I want to have the email that goes out saying, we've received your complaint, here's your complaint number, and it goes to that complainant. That will be there on go live. What we want to do and to notify the complainant, because email is not considered confidential in all regards, we're going to be having triggers on some of those activities that I showed you, like key milestone ones. When something happens and an update happens, the complainant will receive an email basically saying, there's been an update to your complaint in the complaint tracking system. Log into the complaint tracking system to see that. So they won't actually get what information was updated in the email, because again, email is just, in the strictest standards, not considered secure. It will let them know that you have an update in the complaint tracking system. Log in to check it out, kind of a thing. We can make all of that was one of the suggestions made during the interested parties meeting early on. But we don't need to build that functionality into the complaint tracking system, because that can be built into Breeze. We can do that with interfaces made in Breeze. So Breeze will send out the email letting them know that there's an update, and the complaint tracking system is a place to view that update. So we'll be able to configure those as we go live and on an ongoing basis when new activities and things like that are determined. Eventually, we would like to be able to pull documents out of Breeze to show them right in the complaint tracking system too. So the second bullet point here is viewing electronic copies of the original complaint form. Sometimes complaints are still submitted on paper. In the case of those, when they're not submitted online, when they're not submitted online, the summary information I showed you up at the top isn't available. If it gets scanned in as a document, it's attached to the complaint in Breeze, the analysts don't take the time to bother recapping and typing all of that stuff from the paper letters in. So they will eventually be able to hopefully pull that document up, view it, to make sure what they submitted is the same thing that the complaint analysts are reviewing there. We want to have electronic copies of the letters that go out. Again, right now, all communication is done through paper letters. And so when we generate those letters, we attach them in Breeze. We'd like to be able to pull those letters out, show them right through the complaint tracking system. Maybe they can view their letter electronically through the complaint tracking system faster than the postal mail can deliver it one day. We want to log those messages directly into Breeze, as I commented on early. And one of them that I've already kind of got a working idea on would be able to upload files directly through the complaint tracking system. So with that medical release, I mean, we all see that medical release happening on all these complaints. Initially, when they first add that activity on there, it'll be pending. And so when it's pending there, we would like to have a link, right, where you click onto that link, the form opens up, you fill it out, and you submit it electronically. And we believe we can do that through another system we have, and kind of integrating them all together. So these are, again, all after release 1 goals, but I just wanted, some of these were from those interested parties meeting and suggestions that we received there. So just wanted to comment on those. So happy to take any questions.
Thanks, Sean. This looks great, in my opinion. It's, I wish from the state bureaucracy perspective, it didn't take as long as it takes, but that is what it is. But this looks terrific. I really think we're headed in the right direction. Questions, comments? We'll start with Dr. Thorpe and then go to Jonathan.
So Sean, obviously one of the obvious delays, and it's not the longest delay, but that's a delay that's obviously very early, is that request for release of medical records. And is it possible in the initial filing of the complaint to just have them, it seems like if everyone's going to need medical records, why not just have them give the consent to request medical records up front and just do that as they file the complaint? Is that not possible?
So it is in Breeze, when you're submitting your complaint, it's linked there, and it's it's linked there, and they're asked to do it. I don't know if Shar or anyone from enforcement could comment on. My understanding is many of the complaints we receive, the instructions are not followed. It's there and it's asked to be submitted, but it's not. And so you can submit it with the complaint, but again, my understanding is a lot of time we don't get them and we have to follow up and get them.
Well, I mean, can we make it, I mean, usually if, if there's something that you want to have done in a form, at least in many other settings, it won't let you submit the form without, it says, would you please fill this one out because we can't submit it without this.
Attachments cannot be required in the Breeze online complaint form at this time. I can look into if that could be done.
I mean, it just seems like it's kind of an obvious thing to 2 weeks of time.
Absolutely. And some of the examples of complaints I've seen, it does come in and that isn't there. We've added lots of language to not hopefully catch people's attention and get that put in there. That's part of that complaint form redesign project. It's a big, long, admittedly ugly form that we're working to clean up. And so part of it might be that length that people are tired of reading at a certain point. So hopefully we break it up and make it into smaller screens of less reading each time. Maybe we'll get a little better traction there. And the idea I have for the complaint tracking system to be able to submit the form right through there, we could also embed that same type of link so it can be done, filled out electronically, signed electronically, and submitted electronically. Like from Breeze, it just opens up a little different window and you do it right through Breeze. And I think that could also increase, people's, right now it takes them to a form and they've got to go fill it out, and people that are savvy and can fill it out online can attach it right in Breeze and go. But sometimes people just open that form up, submit the complaint and go, I'll do it later. And I imagine ultimately don't. So
yeah. Otherwise, good, really good. Yeah.
Yeah.
The question, or Ms. Runke, you're up next.
Oh, it was just a simple question, because when you started off and you were talking, it looks great, by the way, Sean, and impressive that we're to this point, because I've been in many of these projects that never really launch. So, but my simple question is about the email, because you said when they submit the complaint, then they're going to get an email response with the number. So obviously some people aren't going to want to submit an email. Does that mean they're just not able to log on to get the information?
Yes, with the security requirement of having that second factor authentication, basically sending them that code to that email. If they don't provide an email, there's no way we can have that code to verify it. They are who they say they are.
Okay, thanks.
And part of the, I showed you logging in as the complainant right now, where we're actually creating a new involved party type in the Breeze system called the complainant authorized representative. And so as part of that complaint form redesign that I was telling you about yesterday in Breeze, they'll be able to go in there at go live of this system. And when they're submitting their complaint online, they can add authorized representatives that they want to allow into the complaint as well. One of the goals would ultimately be to maintain that list of people, because right now it's like right when you submit the complaint, you got to put them in there. And then once you submitted the complaint, they are who you said they were. And if you want to update that on an ongoing basis, you'd have to use that email form to send an email to the analyst to have the analyst add them or remove people as well too. So we'll be displaying those individuals that you've essentially shared your complaint with. And if you want to maintain that list, you'll have to contact the analyst basically to remove. Someday we'd like to have it so they could edit that list themselves right there. But that again would require writing back to Breeze.
Thanks, Dr. Yip.
Yeah, great. I was going to ask the same question that the complainant, the family, whatever that want to be notified or they can access, they need to read certain kind of consent forms, their ID, etc., to be checked, right? It's not like I can give my 3 other people, hey, they can access my complaint history. Second thing is that, what about the respondent, the attorney? Can they also say, hey, I want to be listed as one of the person I can access the tracking system to on behalf of the respondent?
The complaint tracking system is for complainants and their authorized representative only. There's not going to be any respondent access or any on any attorneys or anyone on the respondent side being able to access the complaints. Because the complaint is allowed to follow up on the status of the complaint, but it's anonymous to everyone else until it reaches certain stages, you know. We do know we can't stop people from sharing an email account like what I'm using here in this developer tool, this public email box to let people, they could share the complaint information and let people into their complaint. They can add authorized representatives. Basically, we're going to take the stance of it's the complainant's job to keep their information secure. If they share it, they're not, you know, we can't stop people from giving people access to their mail accounts and telling them their complaint numbers and things like that, and adding authorized representatives if they like to. So that will be up to the complainant, but we just know that when you submitted the complaint, you told us this was your email address. That's the email address that we're going to use to contact you to send emails and these one-time passcodes. So it's as secure as we can make it in terms of access, but we can't protect from the other end openly sharing their information, taking screenshots, that kind of thing. Thank you, Tyler.
Other comments?
And just Ms. Remkes, I know it's it looks like it's been a long project. I'd like to thank our lead developer, Frank Islami, that's been working on this. He started in January on this and has been working also, you know, split time on the iOS application and stuff like that. So even though it sounds like there's been all these running years, the idea was so flushed out that by the time we turned it over to him, he's made what I think is quick work on all this. And
That's great.
I usually give him like napkin notes and he makes these things happen. So,
Mr. Watkins, do you have a comment?
Yes, great job. And just a question. So when, you know, it goes to the central complaints unit and then it gets handed over, there's this section at the bottom where they get to have feedback, right? And you said that when it's not assigned to a person, it goes somewhere. Does it go to the liaison office so that somebody can always be on top of it? Or when it's at that level, the first phase, and at HQI, if it goes to HQI, where's the catch-all there?
So maybe I misspoke, but so the only time a complaint would not be assigned to somebody would be when it is closed. Right?
Okay.
It kind of goes into a closed bucket. It has a memory of who the last assigned analyst was, who the last person was assigned to, but we're on a closed complaint, we're going to route those to a different contact because essentially it's off that analyst's desk at that point once it's closed. But when it's open, it's always assigned to somebody, whether it's in the central complaint unit, the complainant liaison unit, or HQIU or CIO or any of our different units here. So those, the individual person, right, will get an email. Say it's assigned to me, right? I'll get an email in my mailbox saying that Troy McClure trying to contact me about his complaint and he sent me this message. But I'm in San Diego for a board meeting, so I can't answer that right away. So it will also go to a catch-all group where the manager of the unit and things like that can access that to follow up those complaints. Because the way we're doing this contact form, and it's for state of California security policies, we can't put an email address right on the website anymore. And so it's different. Like when you send an email to me, and if I have an out of office message, you get a bounce back from me saying that Sean's out of the office, you know, and I have a message there to contact somebody else while I'm gone. Well, with this complaint form, where they fill out the message to basically protect us from outside security threats like phishing attacks and things like that, that you hit submit on that and you don't get any notification if there was an out of office or anything else like that. So we needed some sort of a catch-all in the case of, you know, someone being out, let's say on a long-term leave for whatever reason. Usually the complaint would be reassigned, you know, but if it's just a couple days into the vacation, it may not be reassigned yet. So this catch-all bucket for now.
Well, awesome. So the exciting part is launch date.
I have personally reviewed hundreds of complaints. Like I mentioned yesterday, I have, I think I've taken Reggie and Marina and Shar and Carrie and all the whole exec teams. I think I probably stole 20 hours of their time in the last 2 weeks to review things, and we've made a dent. You know, I mean, I'm happy with how this looks and stuff like that, but we're literally one of these activities. Sometimes we'd be discussing one description of an activity for 2 hours, to asking AI to rewrite it in plain language for us and trying to clarify things. And then when you start looking at it in the full list of all the different activities, and you see how this activity pairs with this, and are we being consistent language throughout and stuff like that. So development's done, and this is working, this is happening. I expect stylistic changes and maybe some text change and things like that, but the big brunt of the work now is reviewing hundreds of complaints with the executive team, with the enforcement team. We're still targeting, and I still think it's totally doable, that the end of 2025, beginning of 2026 was always our goal. The project approval lifecycle documentation schedule that we came up with 6 months development, 6 months of testing. So the development pretty much on track, and the testing, we plan on spending the rest of the year kind of testing all this stuff out. After we've reviewed it here internally, we have to review it with HQIU and AG's office and get everyone's blessing before we go live. So I think by the next board meeting I'll have a better time frame for you, but I'd say we're still on track for the end of the year.
Other comments, questions? Anyone in the room with public comments or questions? How about online, Sean? Let's check.
Yeah. First up here, we have Michelle M. Michelle, you should be receiving that prompt.
I am Michelle Montserrat Ramos, and I'm a consumer watchdog. Thank you, Sean, for all of your work on this project. I must add specifically for all the new board members on the board, this was not a project that was dreamed up by this board. This is a project that was recommended by me. It was effectively advocated for by our amazing volunteer advocacy team that represents cities across the state, and it would never have happened without the support of Dr. Yip. Thank you, Dr. Yip, for supporting a recommendation from the public. I also must add that this is another project that senators from the Senate Rules Committee lauded this board for undertaking, a project that was recommended by advocates, your public stakeholders. I think it's important to state this because it indicates how the board once used to work with advocates and the public on issues and projects that would not only benefit the public, but would also help enforcement staff. When it would have been helpful to see the slides before this presentation, I've also requested time and time again that we have a review of the project before this stage, but again, that didn't happen. One thing, I don't see contact information for the analyst who is handling the complaint. That has been a problem with complainants receiving letters without contact information. I do see there is a generic contact form, but it is not to a specific person that the complainant knows is managing their complaint. The intention of this project was to increase communication with enforcement staff, not decrease it. The intention of this project was to be able to track your complaint so you know who has it, where it is in the system, and where you can submit additional information to the staff who currently has your complaint. We are working with the public to become active participants in the enforcement process. We are not members of the public who just submit complaints and hope for a good outcome. We participate, we seek investigations through other entities. Therefore, we do have additional information to provide as our complaints move through the process. Once I see per your demo that the complaint has been referred to a field office for an investigation, but again, no contact information. Please understand we are stakeholders in this process. Yes, we are here to ensure that our complaints are reviewed and investigated and hopefully go to accusation, but we also understand that it takes our participation to ensure that our complaints make it through the process. We need to know who has our complaints in order to effectively manage our complaints and provide board staff with the information they need while the complaint is still in the process. Regarding medical records release forms, our advocate families have signed their medical record release forms, yet they get requested up to 4 additional times to sign a release form they have already signed. Again, thank you for your work, Sean.
Thank you for your public comment. If I could, and I just want to, maybe I didn't point it out. So we did do interested parties meetings and gathered those requirements. And during that project approval life cycle, those requirements were baselined in documentation with the objectives that we were trying to make. Once we received approval to move forward with this phase 1 release, I'm not allowed, it's called scope creep in the IT world, and we're not allowed to change the requirements now at this point. So that's why after those interested parties meeting where we requested public feedback and the suggested functionality, and then we reviewed them at the following board meeting and discussed it, held public comments there again, and we approved those minimum viable product requirements. That determined what the system was going to be right then and there. So again, all those future enhancements and things like that I talked about, there's always the ability to add to it. But for this first release, I have to stick to that window of what we set out to do there. So I just wanted to point that out. And again, the contact info, that was an original wireframe mock-up we did show a analyst email address there. Since then, state policy has been statewide. You can't have an email address on your websites anymore. It's the first thing an organization would do if they wanted to try to attack the board or any state department or any business in general is they would have a bot scrape your whole website looking for email addresses and target those for phishing campaigns and all kinds of things and stuff like that. So we've been told we cannot have email addresses, even the webmaster email address can't be on the website anymore. So we've switched everything out on our website to contact forms like this, and that change was based on that being changed there. So I just wanted to point out, yes, we did have a screenshot one time that had the direct contact information, but ultimately it's delivered to the same place. It's just we can't show that email address because an automated scraper would use it to attack. But thank you again for your public comment. We'll go next here to Rob Gordon. Rob, you should be receiving that prompt.
Yeah, hi, Sean. I kind of wish I could learn how to not have empathy. It's just kind of natural to me, because that failed demo you had where everybody had to take a break, and I'd just be too much of a hypocrite if I ripped you a new one for that, because it's happened to me many times. Applications seem to know when you're doing something in public. But I do have a few comments. First and most important, and I've said this repeatedly, I will keep saying it, and on an emergency basis, you have to notify the public to not fill out that form, no matter what. People need to know that they're going to be losing all their legal rights if that form is submitted. There's some things you could do to mitigate that. Nice concept from the legal field. I wasn't allowed to say it in the meeting yesterday. I was shut down. My freedom of speech was taken away. But first and most important, some way has to be found to warn the public. And also, no one should ever submit their medical records to the Board of California, ever. Your medical records are not private. I watched both the Office of Administrative Hearings, the Attorney General, having a field day with false entries in my psychiatric record. Nothing I could do, nothing I could say could change that. So we really need to warn the people of the community about that. Now, a few other things, there's nothing that will happen from this, but everybody knows one of the solutions that would solve a huge number of problems. I don't want to help the medical board. Again, I want to abolish them and demolish them. But the second a person, if you did have a legitimate system, the second the person entered a forum complaint, that should be published. Your only role should be to verify the person really saw the doctor. Other than that, even rudeness. So, you know, I saw this doctor and he's rude to me. Fine, you verify that person really saw the doctor and it is public. You know, maybe without the person's name or with it if they want. So number one, I wish you had also talked about that black box a little bit. What you're putting together looks very, very kludgy. It's hard to build a kludgy system. Looks like you've done it. But you know, that's simply not going to work. You started this, it sounds like, would you say 1923? And now you're saying it might be done sometime in 1926. That is ridiculous. It's never going to be implemented. Admit it. I'm sorry. Anyway, thank you. Do not fill out that form, anybody. It's horrible. Thank you.
Thank you for your public comment. Next here we have Marion Hollingsworth. You should be receiving that prompt, Marion.
Okay, can you hear me?
We can. Please go ahead.
Okay, good. This is Marion Hollingsworth, patient safety advocate. I was hoping I could ask a question since we couldn't ask questions yesterday, but I think this is relevant. On this form, maybe I missed it, but is there a way for the complainant to submit medical records? And the reason I ask that is because sometimes what we are given as patients can differ from what the doctor submits once he or she has found out that they're being investigated, and they can falsify documents. I know because this happened in my case where the doctor falsified consent forms saying that I had given consent over the phone, which my phone records showed that she didn't, but at any rate, it showed that there was falsification. So when we submit information, can we submit records that would show our stance and not just go by what the doctor says? Are we allowed to do that, especially since there sometimes are two sets of records? I submitted my record by snail mail a number of years ago, so it was different than it is now. But if in light of the fact that this is all now computer for people who don't have that technology, can they still, and this is the second question, can they still submit by snail mail if they choose?
Thank you for your public comment.
That's no, I don't get a chance to get it.
Ms. Hollingsworth, as you know, this isn't a back and forth, but I just conferred with Ms. Webb, and those records, your records can be submitted already today. I'm not sure the complaint tracking form is going to have a separate process for submitting those records, but those records can be submitted already, as you noted, via mail or otherwise.
Okay, thank you so much.
Thank you. And I didn't want to take any more of your time if you had more public comment there, but just to follow up on that point, again, the baseline requirements for the minimal viable product for the complaint tracking system was to be able to send a message. Files, the minute you introduce files, there's security concerns because we don't know who's mailing us what files that have viruses, things like that. So it's a big ask to add that, even though it's just attaching a file, we still have to make sure it's secure and, before analysts can access it and things. So that's, ultimately one of those enhancements, but you could right now send a message and say, I would like to send you some files, and we can set up a secure way, just the way you were if you were doing it with phone or paper letter contacts right now. So,
okay. Thank you so much. I appreciate that.
Yeah. Next up here, we have Tracy Dominguez. Tracy, you should be receiving that prompt.
Hi, I'm Tracy Dominguez from Bakersfield and also with Consumer Watchdog. My concerns was that Sean did not submit the materials for this presentation we will have to watch this presentation, come up with questions and our comments following the presentation. I wish we had more time, but thank you.
Thank you for your public comment. We will post a recording doing a live demo. There's not a lot I could have posted, but we will have the video up as soon as we can next week for everyone to review. Thank you. Last in queue here, we have Eric Andrus. If anyone else would like to make a public comment, please raise your hand or type something in that Q&A window. Eric, you should be receiving that prompt.
Got it. Come on, mean girl, Christina. You guys have back and forth anytime you want. If you want to correct somebody, you have a back and forth. Sean had a back and forth with Michelle on this, so don't say that you can't have back and forth. It's suggested that you don't do back and forth. It's very much legal. Also, Sean also says things from time to time when he talks about this program that just isn't true. He said today something about you can't put email addresses on government websites. Well, just very quickly, I pulled up the Contractor State License Board website, and on their contact page, they have at least 14 email addresses. I pulled up the Bureau of Automotive Repair. There's email addresses on there. He said you can't even put the webmaster's email address on it. It's apparently not true. So why does he say these things and then not cite, law or code sections about it when it's very clear we can just go online and see that it's not true? Take a look at the Contractor State License Board website. There's 14 email addresses right there on the contact page. Thank you.
Thank you for your public comment. At this time, I don't see any additional requests in queue.
All right, we will bring it back to the board. Any follow-up comments or questions? All right, seeing none. Sean, thank you again, and thank you to your team. I don't have their names at the tip of my tongue, but thank you to the team that is working on this. We really appreciate all the hard work, and we are very much looking forward to it going live.
If I could throw one more name out there, it would be Nicole Kramer, who was our prior enforcement breeze analyst. She left and she's working at the Department of Consumer Affairs now. She did so well here. She got hired over there as their Chief Policy and Analytics Officer. So
Terrific.
That's one of those positions I'm currently recruiting for to fill behind her shoes, but she helped immensely in the early stages of building this. And then, like I said, Frank Islami, the developer. So I'm just here to show it to you, but they did a lot of the heavier lifting.
That's great. And again, thank you for all your hard work. And thank you to the advocates as well that pushed us to make this happen. I look forward, like I said, to having it go live at the end of the year, beginning of next year. We'll move on. Agenda item 16, officer elections. I will accept nominations for either a slate, which is for president, vice president, and secretary, or for individual positions. Dr. Thorpe.
Madam President, I move a slate of officers for Medical Board of California leadership. For President, Christina Lawson, for Vice President, Felix Yip, and for Secretary, Veiling Tsai.
Thank you, Dr. Thorpe. Any other nominations? All right, seeing that there are not any other nominations, I guess we don't need a second on nominations if I'm correct about my rules of parliamentary procedure. And so I think we will go to comments next before we have a roll call vote on that slate of officers. Any comments in the room? All right, Sean, let's open up for comments on WebEx.
Yes, if you'd like to make a public comment on agenda item 16, please do so by raising your hand or type something in that Q&A window. First up here, we have Rob Gordon. Rob, you should be receiving that prompt.
Yeah, I absolutely have a comment on this. Anyone who has been at the Medical Board of California for 5 years absolutely should resign. That is way, way too long. This is America. We don't have kings and queens. I would especially want to encourage, excuse me, I lost my place in my, I would especially encourage Christina Lawson to step down. Christina, you've done a lot of damage, but obviously you don't have to spin it that way. You can say you defended the profession. the physician profession against all enemies, foreign and domestic, for 5+ years. You'll look wonderful on your resume. You'll be able to get lots of business off it. You probably already are, but everybody should vote against this. That is way, way, way too long. This is already a failed institution. You need new blood desperately. I would bring in systems engineer, CEO that's a customer service executive. There are all sorts of people you could get, not just doctors and lawyers. That's not the only problem. The composition of this board, there are serious structural problems. And by the way, I am also including you, AJ. I said yesterday I'm in your fan club. I am. You've also been there too long. Anyone who has been there more than 5 years, that's too long. Please step down. Board, do the right thing for a change. Vote against a whole slate. You're betraying people of California. Thank you, but vote no against this. Everyone's watching. Thanks.
Thank you for your public comment. Next request here is from Eric Andrus. Anyone else would like to make a public comment on agenda item 16? Please do so by raising your hand or type something in that Q&A box.
If you all are going to be sheep and continue letting Mean Girl Christina run things, and she does run a fairly good meeting, much better than Dev Gananadev ever did, I hope you all get some balls and start standing up to her and not letting her strong arm you into doing her bidding and the CMA's bidding. Just because she's president doesn't mean she controls the board. She runs the meetings. Be individuals and be the people you were appointed to be and stand up for patient safety. Stop playing these political games. Stop trying to advance your careers. Stop trying to add little quotations on your resumes. Your job is patient safety. Christina Lawson is out to create a political career, and she wants you all to help her do that. She wants you all to do the CMA's bidding. So stand up for yourselves. If you want to put her in and let her run the meetings, that's fine. But stop letting her control this board and run it into the ground. It's been almost a decade that I've been coming to these meetings now. Nothing is changing for the better. It's stagnating. You all are still being criticized right and left, and it's because of people like Mean Girl Christina Lawson. So again, if you want her to lead the meetings, that's fine. But stop succumbing to her weird sense that she thinks she has power and control over all of you and have you do her bidding. It's just ridiculous. These meetings are going to come back to haunt her when she runs for political office. Mark my words. And if you keep her in as president today, we're going to double down and make sure she doesn't keep doing this kind of bullshit. Thank you.
Thank you for your public comment. Here we have Marion Hollingsworth. You should be receiving that prompt.
Okay, can you hear me?
We can. Please go ahead.
Thank you so much. This is Marion Hollings with Patient Safety Advocate. I was wondering why Ms. Lawson is up for a 3rd year as president. For some reason, I thought it was just a 2-year limit for that. It's time to get some fresh blood in there. I would also suggest that someone nominate Mr. Watkins for one of these positions, since he has the public safety as tantamount for this agency and not the importance of the profession. So please consider Mr. Watkins for one of these positions. Thank you.
Thank you for your public comment. This time, there are no additional requests in the queue.
All right, we'll bring it back to the board. Any further comments? Any further nominations? Seeing none, Ms. Struther, if you would please perform the roll call vote.
Dr. Ayala Rodriguez,
Yes.
Mr. Arkatov,
Yes.
Ms. Chung,
Yes.
Ms. Remke,
Yes.
Dr. Solis,
Yes.
Dr. Thorpe,
Yes.
Dr. Sai,
Yes.
Mr. Watkins,
Yes.
Dr. Yip,
Yes.
Ms. Lawson.
Yes. Thank you for your trust in me, in Dr. Yip, and in Dr. Sai. And Dr. Yip and Dr. Sai, I look forward to working directly with you over the course of the next year on all of the board's important initiatives. Moving on to my, as I always say, my favorite agenda item, which is agenda item 17, future agenda items. Do any board members have requests or recommendations or suggestions for future agenda items? Dr. Yip.
Excuse me. I would love to work with the staff to analyze the 96% complaint that did not end up in discipline. We can report on the nature, the outcome. For example, maybe wrong agency, medical record request, etc. Letter of public reprimand without string attached. What happened to them? The FSMB, they also have existing data that we can help to compare other states. And also the second is to maybe start working on and research on the other state, maybe pick the most populated 10 or 15 state with the help of the SMB about the discipline guidelines. Is it time for update? We're going to task for to review those and get input from all the interest party. Thank you.
Thank you, Dr. Yip. Dr. Thorpe.
Yeah, I have three. I'd like to, the issue of this, the increasing the ratio of PA to, physician to PA in supervising, let's go so from the current ratio is 1 to 4, and the proposed, what I heard was going to 1 to 8. I really think that what I would like to see ultimately is a task force between the medical board and the PA board trying to work on how do we evaluate this and make it work so that it actually is safe and effective and that PAs are actually getting what they need in terms of supervision. So I don't know, I'm not sure if that's an agenda item or just a question. I'm not sure what the right way to do that is. Secondly, one of the things that really concerns me is that the electronic health record has, nobody wants to go back to paper. I understand that. But the electronic health record is a disaster in so many ways. And I think just some kind of an assessment of how the electronic health record has clouded the practice of medicine. It's a pejorative term, I realize it, but it has helped in many ways, but it has also created a lot of problems. So just a realistic look at what the impact of the EHR has been on the practice of medicine in California, if we could do that. And then lastly, sort of related to that, but separate, I think actually, is AI in the creation of medical records. It is going to be a huge problem, and it already is becoming a problem because records are being created that are actually questionable as to the veracity of what was actually done in that visit. It used to be that if it wasn't documented, it didn't occur. That was kind of the mantra. Now, you can't be sure that if it's documented, it actually happened. There are so many fake physical exams and review of systems and all this. It's really troubling. So anyway, those 3 items.
Thanks, Dr. Thorpe. Others? I just wanted to flag for our staff. I heard 2 yesterday that I want to circle back on. One, the impact of immigration enforcement on just in the limited context of our jurisdiction on our potential enforcement activities in the future. That could be a very broad topic as well, but I think what I was hearing yesterday from Dr. Mahmood, who couldn't be with us today, is that impact on, to the extent that there's a physician that's protecting patients or has an interaction with federal law enforcement in one way or another, how that could potentially affect our own enforcement processes. And then 2, the maternal mortality study as well. We should have a circle back on that at some point in the relatively near future. All right, I think we need to go to public comments before we move along. Any public comments in the room? Sean, are there public comments on future agenda items online?
Yes, if you'd like to make a public comment for future agenda items, please do so by raising your hand or type something in that Q&A window. First up here, we have Rob Gordon. Rob, you should be receiving that prompt.
Yeah, I have several, I think 5. But first I want to make a couple comments on the comments that were made. First, Dr. Yip is absolutely correct. Your 97% failure rate should be looked at, should be considered. Anybody that fills out that form knows they have a very minuscule chance. I think it's way lower than 3%. But yeah, that absolutely needs to be looked at. Dr. Thorpe's comments about the physician assistant program. As you know, I was shot down by your chief legal counsel. I was not allowed to share important information I tried to share yesterday in a very insulting way. So I won't do that now. I had critical information to share with you. I'm not going to bother to try. So let me move on to the agenda items. I don't think you'll do these, but I don't think you do anybody's. But number 1, a discussion of the total disregard for basic constitutional rights and American values by the Medical Board of California. That is critically important, especially that form. You have to warn people immediately about that form. They'll be losing their legal rights. And number 2, this is also for Dr. Thorpe, systemic system failure. You need to know about that. This is a systemic system failure. So you guys like it when doctors come in and give you presentations, or there's discussions about other failed programs that you think have been successful. So get a systems engineer or somebody like that to explain to you what systemic systems failure is, because this is a systemic system failure. Like I said, a fish does not know it's in water. You guys are all in the middle of a systemic system failure. Number 3, a discussion of the extreme level of economic damage being caused by the Medical Board of California. We never talked about this, but on the most basic level, it's time you waste when people think they are getting their complaints processed by a responsible regulatory agency, and they don't know what you really are. In systems theory, by the way, that is called posit. The purpose of a system is what it does, not what you say it does, what it actually does, and what you actually are. Best case is the defense attorneys for anybody who complains about the Medical Board of California. In my case, you were the prosecuting attorneys. You directly shared information, never talked to me again, directly shared information with the attorneys, and I never got to say anything. You also want to look at forced urine testing. I want to talk to UC San Diego Health about this, forcing people to take urine tests. I'm part of the zero tolerance program for UC San Diego Health. I've been declared as a drug addict by them. I think anybody who orders a urine test should also have to take one, and I will too, to prove I'm not a drug addict. He who passes the sentence should weld the sword, so you should all have to take the same urine test you order for other people. I have others. Legislative.
Please conclude, Rob.
Okay, real quick. Legislative, you need to look at how much time you're spending on legislative activities, and consider the possibility if you did 0 legislative work. That would make you such a different kind of agency. So, okay, I'll let other people talk. Those are my agenda items. Thank you.
Thank you, Rob. Next last request in queue here is Michelle M. Anyone else would like to make a public comment on future agenda items? Please do so by raising your hand or type something in that Q&A window. Go ahead, Michelle.
This is Michelle Montserrat Ramos, and I'm a consumer watchdog. I agree with the impact of immigration ICE raids on doctors and medical staff attempting to protect patients. And of course, I agree with the maternal mortality, maternal health report that the board promised the public. I'm also recommending discussion on how the complaint liaison unit's duties are, what type of interviews they are responsible for, and which complaints go specifically to the CLU, and also to bring California Department of Public Health to a future board meeting to discuss how they can work with this board to share pertinent disciplinary and investigative information that will help your enforcement staff effectively review and investigate our complaints. Thank you.
Thank you for your public comment. At this time, there are no additional requests in queue.
All right, thanks, Sean. Thanks to all the board members. Thanks to all the members of the public that joined us. Thank you to our terrific staff for putting together another great meeting. We appreciate everyone's participation. Our next item is adjournment. The board's next quarterly board meeting is December 4th through 5th of this year, and there being no further business, this meeting is adjourned. Thank you all.